Um, Today is my great pleasure to introduce Dr. Craig Fryman from North Shore LAJ here to give grand rounds on advanced ultrasound and point of care ultrasound for critical care
Good.
interventionist. Um, Dr. Fryman is uh, currently sorry, an assistant professor at North Shore LHA Hospital and the Zucker School of Medicine at Hofstra in Northwell. He current practices in both the ICU and as well as a lung transplant pulmonologist with their rapidly expanding lung transplant program. He did his residency at Stony Brook in Long Island and then fellowship in pulmonary critical care at LIJ Northwell. So it is my great pleasure to introduce Craig, and thank you so much for doing this.
Thank you. Thank you. Everybody can hear me?
Yes.
Yes.
Okay. Perfect. Perfect. Thank you for the introduction. And I'm honored to speak with you today about advanced techniques in critical care echo and point of care ultrasound. And I hope to highlight some practical applications for the intensivist in a wide range of ICUs, including the ED. So I have no financial disclosures. Just to go through some of the objectives, I'd like to discuss Doppler as it really forms the backbone of advanced critical care echo. Without getting too granular with regard to the physics, it really is an essential part of echocardiography, specifically for how we use it in determining how we manage our patients. So I'll go over some of the modalities of Doppler that we use and discuss some of the pitfalls. And then I'd like to highlight a list of common things that we use critical care echo for, specifically the more advanced techniques. And I'd like to highlight how we use it in assessment of patient stroke volume, how we look at diastolics, specifically looking at left ventricular filling pressure. I'll go over right heart function and how it ties into the pulmonary circulation when we measure pulmonary artery systolic pressure. And then I'd like to highlight a case of systolic anterior motion, a disease entity that we see that we often probably is under-recognized in the ICU, particularly in our patients who present with refractory shock state. And if we don't look for it, we won't identify it. Identification, obviously, of SAM is something that will alter your management. And then I'd like to end with assessment of preload sensitivity, and to piggyback off of that, how we approach patients who are preload sensitive in terms of future applications and some newer data out there that we can use when we evaluate these types of patients who are hypotensive. And we want to know if volume expansion is the right answer. So going beyond the basics, to excel at advanced critical care echo, we have to nail down our ability for image acquisition and image interpretation in real time. Some of the advanced techniques that we use, like I said, we use Doppler. We will employ M mode, which is a more primitive form of ultrasound. And then we go beyond the standard 4 views of basic echocardiography to answer some of our questions. So let's start with Doppler. So these are the three modalities of Doppler that we often employ. On the left, we see our pulsed wave Doppler. This is a very typical image of mitral inflow velocity, where your pulse wave Doppler is within the LV cavity, and you're looking at blood flow during early diastolic filling, followed by your atrial kick, and you have 2 waves there. And we'll talk a little bit more in detail about when we use pulse wave Doppler, what are the pitfalls of pulse wave Doppler. Specifically, one of the issues is that it can only pick up on low velocities. So when we are looking at blood flow velocities that are high velocity, for example, in aortic regurgitation or stenosis, we require continuous wave Doppler. Continuous wave Doppler circumvents one of the limitations with pulsed wave, but it also has certain pitfalls that we'll go over. And then color wave Doppler is a Doppler technology. It's a form of pulse wave Doppler that we can employ during 2D imaging, and it allows us to qualitatively assess the velocity. We cannot quantify it, but it is also very helpful for directionality. So there's a standard color coding. Blue is going away from your probe, red towards your probe, and it also helps us more optimally place our continuous wave Doppler when we are trying to measure maximal velocity of a jet. So with pulse wave Doppler, it uses one ultrasound crystal, and that crystal sends out an ultrasound beam, and that beam will travel through a medium, hit its target of interest, and then come back to the probe. Now, the beams that come back to the probe then is processed by the computer in the ultrasound machine, and it graphically provides a picture for us. Now, this sequence of transmission, waiting until the beam comes back to the probe, this sequence occurs at an interval termed the pulse repetition frequency, or the PRF. The PRF is a depth-dependent variable. So the deeper a structure is, the lower the PRF, and the more superficial a structure is, the higher the PRF. And the higher the PRF, the more able we are at accurately measuring a velocity. So if a blood flow velocity, for example, exceeds a certain velocity for a given depth, it is said to have exceeded the Nyquist limit. And the Nyquist limit is essentially the maximal velocity that can be measured accurately by a pulse wave Doppler. Now, when you exceed the Nyquist limit, what you see on the screen is something called signal aliasing. And on the upper right-hand part of the screen, this is an example of signal aliasing that we see on the left and a little bit more to the right side of the screen. So this is an apical 4-chamber view, and your pulse wave Doppler is situated in the LVOT. Really, it is an apical 5-chamber view. And so we're looking at the LVOT, and we're looking at that downward deflection triangle. This is what we're measuring. But we see on the side that there's something else going on. And we can't really see the velocity. We don't know the direction because it's above and below the baseline. So this is what signal aliasing looks like. Now, signal aliasing or your Nyquist limit is not exclusive to ultrasound. It occurs in other things, specifically the way our brain processes images or the way video cameras will process images. So I have an example here of a very typical example is looking at the spokes of a wheel or propeller blades. It looks like initially it's coming counterclockwise towards us, then all of a sudden it looks like it's switching. And this is essentially what is happening graphically when we use pulse wave Doppler on high velocity jets. And it might get to a point where you're looking at a propeller plane and all of a sudden it looks like the blades are not even moving, which we know that they are moving because the plane is in flight. So this is one of the limitations, and this is a nice real life correlation. So back to pulse wave Doppler. So it allows us to sample velocities at a specific site, which is important when we're specifically looking at the LVOT or in the main pulmonary artery, for example. But we can only record low velocities. Some of the general pitfalls with Doppler is we have to often deal with suboptimal angle of interrogation. So when you're looking at a blood flow velocity, we want to make sure our angle of interrogation is 100 is parallel with that flow. Anything off, you'll underestimate the velocity. There's translational artifact as well. The patients are breathing, the heart is a moving structure, so it's often you will often have interference with that in that regard. And then poor sample volume placement. If you're looking specifically at let's say in the LVOT and your sampling envelope is too close to the aortic valve, you're going to have flow acceleration and you will overestimate the value. And similarly, if you're too far in, if you're too deep into the LV, you can underestimate. So this is the example just blown up where we see signal aliasing on the left. And in fact, this was an aortic regurgitation jet. Okay. Now, if you're to use CW through the same interrogation beam as opposed to PW, you would have a much better ability. You'd have the ability to actually measure the velocity and assess the directionality. So this is a nice example where it's much clearer when you're using CW. So CW overcomes this limitation of the Nyquist limit by using two crystals. One is continuously transmitting and one is continuously receiving. And this allows us to record high velocities. The disadvantage is that you are recording velocities all along that beam. So that's why the signal that we see here, which is a tricuspid regurgitation jet velocity, is all whited out because you're picking up on all these different velocities. Now, there's a certain presumption that along that line, you have to assume where that high velocity jet is coming from. So to go back to our example of the LVOT, if you think the patient may have aortic stenosis and you're going to have flow acceleration in the ascending aorta right distal to the aortic valve, you will have flow acceleration from the stenosis. But if you have flow acceleration from a subaortic membrane or dynamic LVOT obstruction, you will also get a high velocity jet using CW. You just have to look at other characteristics that may lead you to make that assessment. So we don't just look at the velocity, we look at the morphology of the jet, and this may give us clues as to where this is coming from. And then with color flow Doppler, it's a form of pulse wave Doppler. It allows for more directionality and a qualitative assessment of velocity. It is a gain-dependent modality, so you can easily be undergained or overgained. A good rule of thumb is if you put your box as small as possible to cover the area of interest, and that will improve your resolution. You keep the gain very low, and then you slowly work up to a point where you have where you feel is a nice jet without too much interference. So let's go into some of our examples. How do we assess stroke volume assessment? So I'll use a case. So this was a 20-year-old male, history of asthma, had presented with abdominal pain. He had some shortness of breath. He has abnormal vitals. He's tachycardic, relatively hypotensive from when he came in on admission, and relatively hypoxemic on room air. He has a mild leukocytosis and a mild lactate. So he had a CTPA. Looks like there may be some left lower lobe consolidation there. And the CT abdomen showed terminal ileitis and some suggestion that there might be acute pyelonephritis. So an ICU consult was called for this young man because of his abnormal vitals. And to our surprise, what we saw is in this parasternal long axis view, we can see that there's dilated LV, severely reduced LV systolic function. It looks fairly global, no wall motion abnormalities, and this is confirmed on the short axis view at the level of the papillary muscles. So the question is, what is this patient's stroke volume? He's somewhat hypotensive. He has somewhat of a mildly elevated lactate. The way we would approach this is that we need two values. So we look at the LVOT, VTI, the velocity time integral. So we use our pulse wave Doppler. We obtain a 5-chamber view from the apical, an apical 5-chamber view, and we put our pulse wave Doppler in the LVOT. And essentially what the VTI, the velocity time integral, is the distance that the blood moves through the column in one stroke volume, in one heartbeat. You're looking to establish the height of a cylinder because we assume the presumption is that the LVOT is a cylinder. So in this case, the LVOT was measured as 9.07 centimeters. So that's our height. The next, we need our area. So we obtain a diameter of the LVOT right underneath the hinge points of the aorta in the parasternal long axis view. And I use this example because the diameter is 2. So the radius is 1, pi r squared is 3.14. And you multiply these together and we get our stroke volume around 30 cc's. If you need the cardiac output, you measure that, you multiply that by the heart rate. So in this case, it's around 3.6 liters. Now, it's not always necessary to calculate an exact stroke volume or an exact cardiac output. In some cases, it is. But in many cases, we can just use the velocity time integral as a surrogate for stroke volume. And the reason for that is the area does not change. It's a fixed value. So if we intervene on a patient, our question is not exactly what is the absolute value of the stroke volume, but is our intervention improving hemodynamic? Is it improving stroke volume? So I'll use this case as an example. This patient had presented with cardiogenic shock. As you can see here, he has severely reduced LV systolic function. And we can see here on the parasternal long axis on the left and the apical 4-chamber view on the right. So what was done for this patient was a dobutamine challenge. Now, what advanced critical care echo technique allows us to do is to assess and titrate the dobutamine without the need for a pulmonary artery catheter. So you can see here initially his VTI is 7.43, which is low. Normal VTI ranges from 18 to 23 centimeters. Started on dobutamine of 5 and it didn't change much. And as you gradually increase the dobutamine and add additional vasopressors, we are able to achieve a VTI of 11.3. If you go beyond that, in this case, the phenylephrine was increased from 3 to 5, the VTI dropped, which makes sense in the setting of cardiogenic shock. We're increasing LV afterload there, and the patient did not work for the patient. So this is an example of effectively using advanced critical care echo with serial exams to titrate dobutamine. Let's move on to another example of how we use critical care echo, measuring diastology. The question is, does a patient have elevated left ventricular filling pressures? So what we do is we're not necessarily interested in quantifying the pressure. We want to know if there is increased LAP, as that implicates the risk for hydrostatic pulmonary edema and often can help distinguish heart failure from primary lung injury in patients who present with hypoxemic respiratory failure. So one of the things that is essential to assessing this is your mitral inflow velocity. So what we do here is, again, we need to know what the velocity is at a specific location, and it's a low velocity. It's a relatively low velocity. So we employ pulse wave Doppler. We obtain an apical forward chamber view and put our pulse wave sampling envelope within the LV where the mitral valve leaflet tips meet. And what we see here is an E and an A wave. This represents early diastolic filling, followed by the atrial kick. Now, obviously, if a patient has AFib and doesn't have an atrial kick, it becomes much more complicated, and this is not always feasible. So patients using this requires the patient to be in sinus rhythm. And on the schematic on the right, we can see a nice E wave followed by a period of diastasis, and then you have your atrial kick. So what happens is that you have your aortic valve closes. Once systole is complete, you have isovolumetric relaxation, and you have this robust drop in pressure within your LV, such that the LA pressure then exceeds the LV pressure, and you have passive filling from the LA to the LV, and that is your E wave. And then to a lesser extent, you have your atrial kick. Now, as this is a nice schematic just showing the pattern that we see as we go to more advanced stages of diastolic dysfunction. So in grade 1 diastolic dysfunction, we're not really dealing with reduced compliance of the LV. This is impaired relaxation. So the biggest thing that is really affected is that isovolumetric relaxation that is blunted, and therefore that blunts your early diastolic filling. So your E wave is reduced relative to your A wave, and you have this EA wave reversal pattern. Now, as you move on to more severe forms of diastolic dysfunction, you start to have increased left atrial pressure, and that augments your E wave, right? Because you have higher pressure gradient now. And in grade 2, it goes back to a normal pattern. We call this pseudo-normalization. And then as you move on to very severe forms of diastolic dysfunction, where you have not only impaired relaxation, but severely reduced compliance, and these patients tend to be hypervolemic, you have a very high E wave to the point where it's time for the atrial kick. There's no more space for that blood to go. So that atrial kick generates a very, very low velocity. So you have an E to A ratio that is very high, 2 or higher. So again, on the left, we have our mitral inflow pattern. One of the other pieces to the puzzle is not looking at blood flow velocity, but tissue velocity. So in order to do this, we still use pulse wave Doppler, but we use something called tissue Doppler imaging. And essentially, when you change it to tissue Doppler imaging on a machine, it automatically will change the filters and change some of the settings to accommodate the lower velocities of the myocardium. TDI is thought to be more reliable than inflow velocities, blood flow velocities. It is thought that these numbers, the myocardial velocities, are less prone to being influenced by volume status. So we use both of these variables to plug into an algorithm that helps us determine whether or not a patient has increased left atrial filling pressures. So here we can see we're looking at the lateral wall. This is in the adjacent to the mitral annulus on the lateral side. We can also look at the septal side as well. And it is the same pattern. You have an E, we call this E prime and A prime, and it's equivalent to your early one. The E prime corresponds to early diastolic filling, and the A prime to your atrial kick. The only difference is that you see a downward deflection as opposed to an upward deflection, because as the LV fills, that area moves farther away from your probe, and therefore it is projected downward. So in 2016, the American Society of Echocardiography updated their guidelines for evaluation of diastolic dysfunction. And there's two flow sheets that we often use. So in the setting of normal LV function, there are 4 things that we can look at. We look at your ratio of E to E prime. we can look at the absolute values of your tissue Doppler imaging. So we can look either at the septum or the lateral. And then you look at your TR jet velocity. Now, you could also, according to the guidelines, you can use the LA volume index. However, that is a little bit more cumbersome. And in the ICU setting, it is not routinely done. So we use generally the first three variables to determine whether or not a patient has diastolic dysfunction. And if we see three of them positive, then we can say it's diastolic dysfunction. And if less than 50% are positive, normal. And we'll talk a little bit more about if the findings are indeterminate. Now, if the patient is found to have diastolic dysfunction, if the numbers support that, then we can move on to the second part of the algorithm. And we directly go to this part in patients who have systolic dysfunction to begin with, because the presumption is that these patients have some degree of diastolic dysfunction. And you can see on the two opposite ends of the spectrum, if we have a low EA and a low early diastolic filling velocity, this is more consistent with a normal pressure. And if we have a really elevated EA ratio 2 or higher, we are dealing with a more severe grade 3 diastolic dysfunction. Anything in between, we follow the middle to sort of differentiate whether it's grade 2 or it's grade 1. Now, if you have a indeterminate finding, then it's possible that we can use lung ultrasound to help guide us in the right direction. Now, these are two just standard examples. On the left, we have normal A-line pattern with lung sliding, and the right, we have B-lines. Now, the distribution and morphology of B-lines will certainly help narrow down the differential. If someone has smooth pleura, bilateral B-lines, pleural effusions, this suggests hydrostatic pulmonary edema. However, if we see abnormal pleural line and it's very scattered or patchy and there's no pleural effusions, this might represent a more multifocal pneumonia process or pneumonitis unrelated to hydrostatic pulmonary edema. So this was a nice study published in 2014, actually correlating wedge pressure with A-line pattern. So when we see A-lines, what is the probability that they have a low wedge? And as you can see here, so these patients had pulmonary artery catheters. And as you can see here, patients with just A-lines and lung sliding, while the sensitivity is okay, the specificity is not great. However, if you add A-line pattern with normal LV function, you have a much higher probability of that these patients have a normal wedge and likely do not have increased LAP. So let's go through some cases to highlight how we employ this. So a 65-year-old male, history of obesity, chronic systolic heart failure, and hypertension, had presented with multifocal pneumonia, imaging findings consistent with multifocal pneumonia, fevers and chills. They were short of breath. That was worse with laying flat, so endorsing some degree of orthopnea. They're hypoxic, a little bit of an elevated creatinine and normotensive. So the question here is, what's driving the respiratory failure? Is it a primary lung injury? There's evidence that there's pneumonia here. Or are we dealing with a component of hydrostatic pulmonary edema that also needs to be addressed? So when we look at this patient's echo findings, we see systolic heart failure. We see reduced LV systolic function, which is confirmed in other views as well. This is just a nice example. And in this case, we had bilateral B lines, no pleural effusions. So the question still stands. So what are our management options here? The management options could be antibiotics with fluids if we think the patient has pneumonia and is septic. We can do the opposite and give antibiotics and diuretics if we think that the patient is volume overloaded in addition to having a pneumonia. Or we can have a more conservative approach and use antibiotics alone. So when we perform our initial step, we look at mitral inflow filling velocity. And we look at our E and our A waves. So what we see here is EA wave reversal. So this is more consistent with the impaired relaxation that we see in more with grade 1 diastolic dysfunction. So if we look at the numbers, we have an E wave of 48.1 centimeters when we have an A wave of 76.2. So our E to A is low, 0.62. And we look at the E wave velocity, which is low as well, 48.1. So if we go down this algorithm, we say, okay, patient has normal left atrial pressure or likely has normal left atrial pressure. So let's give antibiotics alone. Now, I would say the caveat that I always try to be cognizant of is if your ultrasound findings do not fit the clinical picture, then you have to question is there something else going on, or do I need to reevaluate and repeat the the echo and recalculate the numbers? So in this case, clinically, it made sense. The patient had no pleural effusions. The B lines were likely related to a multifocal pneumonia process, and it supported and our findings supported our decision to have a more conservative approach and give antibiotics alone. And in fact, this patient did fairly well, was in the ICU for a very short period of time, and discharged soon thereafter. Another case, this is a 72-year-old female who had with CAD and COPD with chronic hypoxic respiratory failure, already on oxygen. She presented with shortness of breath and hypoxia. RVP is positive for human metapneumovirus. So the CT shows bilateral ground glass opacities and moderate bilateral pleural effusions, and the lung ultrasound showed bilateral B lines in addition to the pleural effusion. So the question here is, again, what is driving this patient's shortness of breath and hypoxia? Patient already has limited reserve, known pulmonary disease, already in oxygen, with a known a positive viral panel with a nasty virus, human metapneumovirus. The ground glass opacities could represent a viral pneumonitis, but it could also represent hydrostatic pulmonary edema. And this is supported by the presence of bilateral pleural effusions. The pro-BNP is somewhat elevated as well. So let's see what we find on the echo. So we have our parasternal long axis view there. We have a fairly normal preserved LV systolic function. Perhaps the LV wall looks a little bit thick, but looks like we're a little bit off axis, so it's hard to make that call. So maybe a very small pericardial effusion there as well. We have our continuous wave Doppler looking at a tricuspid regurgitation jet. We use continuous wave because it's a high velocity jet, and it's measured around 2.9 centimeters per second. We look at our mitral inflow pattern here. We have an elevated E to A ratio of around 2. And then we have our lateral tissue Doppler imaging on the bottom right-hand corner, where we look at the E prime velocity, 5.53 centimeters, which is low. So with these three variables, an elevated TR jet velocity, a low lateral E prime velocity, we can say that there is diastolic dysfunction that's present. The question is, what degree? So if we go down our algorithm, we see that the E to A ratio is 2 or higher, and this is consistent with a grade 3 diastolic dysfunction. So here we make the assessment while the patient is having a COPD exacerbation, likely in the setting of human metapneumovirus, her symptoms are also in part due to having increased left atrial pressure and pulmonary edema as a result. So the decision here was to manage her for COPD exacerbation, but also provide diuretics for her. Okay, so this patient did fairly well, ended up transferring to the RCU, or our respiratory care unit, and discharged home within the week, I believe. So let's look at right heart function now. So right heart function, we'll shift gears a little bit. Best estimated visually in the apical forward chamber or subcostal view. We often comment on size and function. So RV should be around less than 60% the size of the LV, anything between 60 to 100%. We're dealing with a moderately dilated RV. And anything that is, any RV that's larger than an LV, we say this is severe dilation. Now, to quantify the function of the RV is a little bit difficult given the complex geometry of the RV. But we do have the TAPSE, the tricuspid annular planar excursion, that we use to assess RV systolic function. And basically what this is, it looks at the longitudinal displacement of the lateral annulus during the cardiac cycle using M mode. And I'll show you an example. You could also, and less commonly it's done, use myocardial or TDI, tissue Doppler imaging, looking at the lateral tricuspid annulus. And we look at the S prime. Other things, if we are able to, we look at the RV free wall thickness. Anything greater than 5 millimeters suggests that there's some chronic pulmonary hypertension there. We look at septal kinetics as well. Oftentimes you'll see this septal bounce. However, abnormal septal kinetics can be seen in other entities, specifically left bundle branch block in patients who have had prior cardiothoracic surgery. So normal TAPS is around 1.7 centimeters or 17 millimeters. As you can see here, we have M mode going through the tricuspid annulus, and this is the image that we see. M mode is very useful when we're looking at displacement of structures against time. And we'll see how this is useful also when we look at systolic anterior motion. So essentially here we have our y-axis, which is movement of the actual structure you're looking through, wherever your beam of interrogation is, and your x-axis is time. And then we can see here that the lateral annulus is moving 1.7 centimeters, which is, again, sort of at your cutoff of what's considered normal. Just for completeness, when you're looking at tissue Doppler imaging using the same interrogation beam, but you're using pulse wave Doppler and putting your sampling envelope at the lateral annulus, any velocity less than 10 centimeters is consistent with reduced RV systolic function. So this is a nice view. This is a parasternal short axis view. We can see septal flattening and altered septal kinetics here. Now, we can't really see the RV free wall here, but what we can see is that there's septal flattening, and when we often characterize septal flattening, we often try to see if it's more prominent in either systole or diastole. If it's more prominent in systole, this is more consistent with a pressure overload state, and if you see it flattened throughout the cardiac cycle, it's more suggestive of a volume and pressure overload state. The reason that it's more prominent in systole in the setting of pressure overload is that given when the PVR is elevated, the RV takes a little bit longer to complete systole. So as the LV starts to relax, that RV is still squeezing, and that flattens the septum and pushes it into the LV. So this is a nice example of this is an apical four-chamber view in a patient who had presented with a submassive PE. And as we can see here, the RV looks dilated, at least almost 1-to-1 ratio with the LV. So we would consider this a moderate to severely dilated RV. And when we look at the TAPC, it's 1.4 centimeters, which is less than the cutoff of 17 millimeters or 1.7 centimeters. So this would be a moderate to severely dilated RV with reduced systolic function. So to highlight the case of why it's important to look at the RV, we have an 85-year-old female who had experienced syncope while getting out of bed. She was admitted to the hospital for something entirely different, was getting ready for discharge. The family was at the bedside, noticeably became out of breath. She syncopized. Family brought her back to bed. She had developed hypoxia and required O2. So we were called to evaluate her, and we just immediately put the probe on her chest, and we saw that this is an apical four-chamber view. We're dealing with a dilated RV, and more concerning is that we have a clot in transit. We can see this clot within the RV. So this patient was emergently transferred to the ICU, given TPA, and unfortunately she had a lot of comorbidities and ended up at cardiac arresting, and she passed away. That being said, had we not immediately seen this, then she would not have come close to receiving the proper treatment. So any patients with syncope, my first instinct is to get a probe out, look at that RV. Certainly, if we didn't see a clot in transit, the dilated RV would be concerning and would trigger a more extensive workup, either with us looking at a prior echo to see if her RV had been dilated previously, and certainly trying to assess, the degree of her RV function. Now, related to RV function is pulmonary circulation. There are two things that we often use in the ICU when, as it pertains to advanced critical care echo. We often want to know what is the pulmonary artery systolic pressure, and we can't always measure that. So we can look at something else called the pulmonary artery acceleration time, which we will go over momentarily. So calculating the PASP, when we calculate the PASP, what we're really calculating is the RVSP, the right ventricular systolic pressure. In most cases, the RVSP will equal your PASP as long as there is no significant pulmonic valve abnormality, specifically pulmonic valve stenosis. So this is something that we often will know in a history. It's often associated with more congenital disease, but it is something that needs to be taken into account when you're calculating and basing management decisions on a measurement that we take here. So we use something called the simplified Bernoulli equation. Essentially, this allows us to calculate a pressure gradient. So in order to calculate an estimated RVSP, we need to find a tricuspid regurgitation jet. So oftentimes we'll see on echo reports that a PASP couldn't be calculated due to an insufficient jet. So there are many ways, there are several different views that we can use to locate a tricuspid regurgitation jet. We can either find it in the apical four-chamber view. We can find it in the RV inflow view, which is a view that is obtained by starting in your parasternal long axis and angulating your probe. Or we can use the parasternal short axis at the level of the aortic valve. Now, I say this because you should try to find your highest jet velocity to make your calculation. And you establish your velocity using CW, continuous wave Doppler, and then you plug your velocity into the formula, which is simple. It's 4v squared. And in this case, we plug in 2.9 centimeters and we get a gradient of 33.6. Now that gradient has to be added to the estimated right atrial pressure. If you have no central line in place to measure invasively measure right atrial pressure, we could use the IVC to make that estimation, just knowing that it is an estimation and prone to error. If the IVC is large, like in this case below, with, as you can see, there's a dilated hepatic vein there as well, and there's no collapse, the range can generally be thought to be between 10 and 20, and you can use just the middle of that, 15. So in this case, the PASP would be 48.6. Now, again, just like with stroke volume, it's not necessarily always important to quantify, but to know, it's more important to know that pulmonary hypertension is present. So if we're in a situation where we would like to know if pulmonary hypertension is present, we can use the pulmonary artery acceleration time to give us an idea. This gives us a more qualitative assessment. So basically, what this is essentially is that we use pulsed wave Doppler. We isolate the main pulmonary artery, and we obtain this view in the parasternal short axis view at the level of the aortic valve. And you center your pulmonary artery, and you put pulse wave Doppler there because it's a low velocity jet, and we need to know exactly in that location what the velocity is. And you establish this VTI pattern, but we're not measuring velocity and we're not measuring the VTI. We're measuring the time it takes to reach maximal velocity. And the idea behind this is that if PVR is increased, is elevated, and a patient has pulmonary hypertension, the time it takes to reach maximal velocity shortens, such that anything less than 60 milliseconds would suggest the presence of severe pulmonary hypertension. These are two examples where patients had relatively normal acceleration times. Some of the pitfalls in general of you looking at the RV and looking at the pulmonary circulation, sometimes it's not always, sometimes it's difficult and we can't always get on-axis images of the RV. We often want to see the free wall there. Anything off-axis of the LV, particularly in the parasternal short axis, may mimic a D-shaped heart, and you might incorrectly think that there's pressure or volume overload. It is easy to have inaccurate measurements of a TR jet velocity if you are off axis, and you are squaring this number when you use the simplified Bernoulli equation to calculate your gradient. So this will throw your estimation off as well. And we talked about using the RAP estimation based on IVC. It provides a range, and therefore it's a range. It's not exact. So clinical scenarios in which it is important to know and to screen patients for increased pulmonary pressures or impaired RV function. So in the intubated patient, if we see patients who have RV dysfunction or elevated PASP, certainly we can alter the way we ventilate these patients, either by limiting inspiratory pressure, limiting the PEEP, or checking for auto PEEP, anything that will alleviate the PVR. Certainly in the peri-intubation phase of, when patients come in with acute cor pulmonale or, acute on chronic cor pulmonale for various reasons, either they have congenital PAH or they're coming with acute PE, this could be one of the most dangerous scenarios for an intensivist. And so if there is time, we screen patients we look at the RV. If it's enlarged, we take measurements. And this can significantly influence our choice of sedative, whether we want to avoid giving a sedative that induces hypotension, to the point where some suggest even doing an awake intubation. Your initial ventilator settings can be altered, whether or not you start with a very low PEEP, limit your inspiratory pressure, limit your volumes, avoid rapid rise in PVR. Often these patients, as we all know, are prone to cardiac arresting once they are intubated. And if all else fails, to at least have preparations in place for CPR or for initiation of ECMO if that is appropriate for the clinical situation. And in the less common scenario of having a dilated RV but completely normal pressures, consideration of a primary RV failure, for example, an RV infarct, would help narrow down the differential. So let's talk a little bit about systolic anterior motion, under-recognized in the ICU. This study published in 2020, single center, but 527 patients who were in shock and ventilated were enrolled, and 2% were found to have severe LVOT obstruction. So not uncommon. And if you don't look for it, you will miss it. Clinical manifestations of clinically relevant LVOT obstruction, hypotension, severe MR with resultant cardiogenic pulmonary edema, and these are often exacerbated with inotropes and diuretics. So it's difficult to see SAM on a 2D image in B mode. Now here you might be able to see there might be a transmission issue, but you can see that the anterior leaflet may have this kind of double bounce. Oftentimes you have to slow the image down. These patients tend to be tachycardic, and it's difficult to pick up. The first screening thing that you can do is use your color flow Doppler and look for MR. Now, if you see MR, that might trigger you to use M mode and have your interrogation beam along or going through the tip of the anterior leaflet. Now, on the left, I have a normal example of what this looks like. You have your E and your A wave, which corresponds with your mitral inflow pattern when we look at inflow velocities. And this represents your anterior leaflet opening during early diastolic filling. It comes close to the septum, the LV fills, you have diastasis, it comes back down, and then your atrial kick, the mitral valve goes up again. And then in between that, you have systole. Now, in the setting of SAM, you will see that instead of during systole where the anterior leaflet should be down, it moves back up closer to the septum. And this occurs because you have increased high velocity blood flow going through your LVOT, and it creates a Venturi effect. And that pulls your anterior leaflet open when it should be in the closed position. So not only does this cause obstruction with consequent hemodynamic instability, but it also will cause pulmonary edema and these MR, which causes pulmonary edema. Now, some of the substrates that put patients at risk for SAM and that lead me to be a little bit more careful in my assessment is, does the patient have LV hypertrophy? Is there a history of mitral valve prolapse? Does the patient have a stress-induced cardiomyopathy where you have apical ballooning and a hyperdynamic base? These are some anatomic substrates that put patients at risk for development of SAM. Some physiological substrates include use of inotropes, vasopressors with beta-1 activity, and having a high endogenous sympathetic tone. Anything basically that causes tachycardia. Certainly patients who are hypovolemic or vasoplegic will also put patients at risk. So if we identify SAM, we shift to gears, we consider volume expansion and switching off the inotropes and using vasopressors with less beta-1 activity. For example, phenylephrine. Okay, last, I just want to focus a little bit on preload sensitivity. So preload sensitivity is not a new concept. Essentially, what we do is we use pulse wave Doppler. We look at our apical 5-chamber view, which we often do for many different things. And we look at the LVOT VTI pattern. And what we do is we slow the sweep down. We slow the sweep so we see many beats, okay? And what we're looking for, and this is specific to mechanically ventilated patients who are hypotensive, we want to answer question, will volume expansion improve stroke volume and therefore cardiac output? So what we're looking for is a drop in your maximal VTI velocity by 12%. That's the cutoff, 12%. The mechanism behind this is that patients on positive pressure, mechanical ventilator gives a breath, increases intrathoracic pressure, decreases your preload, which is normal. That is an expected phenomena, and you have you will have an expected drop in your VTI. But in patients who are fluid sensitive or preload sensitive, that phenomena will be exaggerated. That effect will be exaggerated, and you will see a higher than normal drop in your VTI. And again, 12% is the cutoff. So on here on the left, we see that you can't see where the calculation is, but this would be consistent with someone who is preload sensitive. And on the right, not really preload sensitive. You don't see much of a difference between your max and your min. Now, normally it would be ideally a patient like this that you're looking for preload sensitivity would have a respirometer attached to the ultrasound but that is not very practical, and most patients don't have that. And most ICUs don't have that capability. So we use our max and our min. So some of the pitfalls to this, we can't use this for every patient. So these patients require positive pressure ventilation, obviously. They have to be breathing passively with the vent. So either deeply sedated or receiving some type of paralytic. You have to have a sufficient tidal volume to pressurize the chest and therefore drop your preload. This is it's set at 8 cc's per kg, so we will temporarily increase their tidal volume when we're looking for this. And the patient has to be in sinus rhythm. A patient who's an AFib will have variable filling, and this is much more difficult to assess. Furthermore, this has not been validated for patients with RV dysfunction, so it limits who you can do this with. In patients who are spontaneously breathing, you can still actually do this using a straight leg raise. A straight leg raise will increase preload by several hundred cc's temporarily, and what you're looking for is an increase in VTI velocity, which would suggest preload sensitivity. Now, you can either measure the actual VTI itself, or you can measure the maximal velocity. It is easier to measure the maximal velocity, which is what we do. So to piggyback off of this concept of fluid responsiveness, which is not new, we often talk about another layer of complexity to this is fluid tolerance, which is a little bit more of a newer concept. So a patient who might be fluid responsive, the question is, are they also fluid tolerant? So fluid responsiveness it answers the question whether or not volume expansion would augment your stroke volume and your cardiac output. Fluid tolerance is more of the question of, well, can your organs handle that? If you have venous congestion, could your organs handle more fluid? So what does it look like when organs are congested? Well, in the lung, it could look like impaired VQ, reduced compliance. In the heart, certainly diastolic dysfunction. In the kidneys, we often see increased interstitial pressure with reduction of renal blood flow and a consequent AKI. Liver, we'll see hepatic dysfunction, and the intestines, malabsorption and ileus. So around 4 years ago, this VEXUS score came out, this venous excess ultrasound score, that tried to establish a means of assessing fluid tolerance. And essentially what it does, without getting in too much detail, is that you look at the IVC. If the IVC is large, if the IVC is small, then we say, okay, patient probably is not congested. If the IVC is large, then we look at 3 specific areas to assess for congestion, and we use the hepatic vein, the portal vein, and the renal veins. And essentially, you're not measuring anything. You're using Doppler signals, and you're looking for patterns. Normally, these flows, specifically within the venous flow within the portal vein and the renal vein, are quite monomorphic, meaning that it doesn't change throughout the cardiac cycle. In the setting of venous congestion, you start seeing pulsatility in these patterns, in the flow patterns, and these suggest the presence of venous congestion. So, if we look to the box on the right, if the patient is fluid responsive and fluid tolerant, sure, then volume expansion might make sense. Might make the most sense. And certainly if they're both absent, if a patient is neither fluid responsive nor fluid tolerant, then we would really not give fluids, and we would even consider diuresis. The interesting part comes when there's a discordance between fluid responsiveness and fluid tolerance. So if a patient is fluid responsive, meaning let's say we look at the LVOT VTI and we have a more than 12% drop when the mechanical ventilator gives a breath, but we see that the patient is not fluid tolerant, then we can consider early vasopressors and not give volume expansion. And if it's the reverse, if the patient is not fluid responsive, but they are fluid tolerant, then a conservative fluid management approach might also be better, because the thought behind this is that if you give a patient fluid, if you give this type of patient fluid, they might end up not fluid tolerant, that they're on the edge. So I think from a physiological standpoint, this makes sense. Using the VEXUS score hasn't been widely adopted. I think more studies are necessary to look at various different patient populations and if it's applicable. I think that there's a barrier. It's more cumbersome. to do more tests and to make more measurements. There's a learning curve to identifying the hepatic and portal vein, and specifically the renal vein, which is not the easiest to obtain, particularly if you're not using a curvilinear probe. Oftentimes, you'll look in the studies that are published measuring using VEXUS, and you see these nice crisp images. They're likely using a curvilinear probe as opposed to a phased array probe, and not every ICU has all these different types of probes to use. So I think from a physiological standpoint, it makes a lot of sense, and not everybody who tests fluid responsive necessarily needs fluids. So something to take into account when we are dealing with our hypotensive patients. So these are my references. This is obviously not a complete review of all things advanced critical care echo related. Each of these topics you can have a whole entire lecture about. But what I hope to do was really highlight a lot of the practical applications of how we apply advanced critical care echo techniques to our patient population. And I hope you all found this talk informative. And I thank you. I thank you for your time.
And hi, Dr. Fryman. And again, thanks a lot for a very extensive, comprehensive, and actually you made it very understandable, a very complicated topic. I think it was very well received. I'll open up the floor, if anybody has any questions.
I'm wondering whether or not there are any ways you can adjust for people with severe chest wall deformities. And then is there another way to handle arrhythmias in terms of trying to make accurate assessments?
That's a great question. I think so. Patients with chest wall deformities, where it becomes very difficult logistically to obtain good images, these are the types of patients that might benefit from transesophageal echo. So, oftentimes, and I didn't really touch on this, but transesophageal echo is a fairly low risk procedure. We often do it in our ICU here if we cannot get sufficient views and we are dealing with a patient with undifferentiated shock, for example, and we need to know what the heart is doing. And we use it in a very specific way. We're not replacing the TE that the cardiologists do if we think that there's significant valvular disease and they need a valve assessment. That's an entirely different indication. Oftentimes, we'll use TE to assess cardiac function in shock state, whether or not patient has increased left atrial pressures, looking at their stroke volume. So I think TE would be helpful in that type of situation. As it pertains to people who have arrhythmias, I think it proves to be very difficult to make these assessments. Oftentimes, some of these patients will require more invasive studies to actually directly measure pressures. There is some data out there to suggest that it's a little bit more cumbersome, but you can take an average. Let's say if you're looking at a VTI, LVOT VTI to assess for stroke volume in a patient with AFib, you can take an average, or you measure 10 different VTIs and you average them together to get a sense. But I don't believe this is not commonly done because it's a little bit more cumbersome and not as validated.
Thank you. Anybody else have any other questions? Yeah, so I think this was great. And as you know, I'm also an enthusiast for advanced critical care echo. Part of, the issues though, it just has to do with people training and being comfortable, doing all these, specialized procedures. And frankly, also the amount of time it takes, right? Okay. You're in an ICU, it's very busy, you have a lot of patients, how do you find time to apply, all these measurements, which again are helpful, but then, it takes a lot of time, and whether it eventually changes your outcome in general.
Yeah, I think I think from a time perspective, I think that is one of the rate limiting steps. In my training and even when I round now in the ICU, I always walk around with an ultrasound probe. And any patient who is intubated, any patient who's in shock, I put a probe on their chest. And to really excel, it really just it's it's repetitive ad nauseum to just constantly do these echoes. And as you get more comfortable and more experienced, they become much faster to do. And yes, I mean, I think especially for the more advanced topics, I think that, you have to read. You need like a critical mass of people around you who are interested to discuss images with, and that's how we learn and grow. And particularly for me, when I became critical care board certified, that taking that exam really kind of pushed me over the edge to really delve more deeply into some of the more advanced topics and the advanced hemodynamics, because not only does critical care echo, I believe, help us manage these patients, but it also gives us more insight into the physiology and hemodynamics of our patient population. So I think there's dual benefit to excel at critical care echo in the ICU. But yes, 100%. I think there is a rate limiting step, and we are all so busy, and it's between seeing our patients and seeing consults and charting to fit it in. Absolutely, definitely a challenge for everyone.
Excellent. Thank you. Anybody else on the line? Yeah, but thanks a lot for doing this. I think we are obviously trying to encourage, our fellows also to, take the boards, be echo boarded. But it's good to see what the practical, applications are. 'Cause I think, as you rightly said, it's very, very important. And it does make a lot of difference in patient management. So, yeah, thanks for doing this. So if there are no more questions, we'd like to thank Dr. Fryman for coming, and we hope to invite you back again, and say hi to all my friends. Okay.
I will. Thank you for the invitation. I appreciate the time. Thank you, everyone.
All right. Thanks.
Bye.
Bye.